everyone to today's session of our NOW program educational webinars. Today's topic will be brain metastases. This program is hosted by the Blum Resource Center. Over at the Blum, we are grateful to the NOW team for this continued partnership. The recording of this session will be posted on our Blum YouTube playlist and our Blum Digital Resource Center. For those of you watching live, if you have any questions related to today's program, please feel free to utilize the chat and Q&A feature throughout the session. At the end of the session, your questions in the chat will be used to moderate a Q&A. If you have any other questions or would like more information about resources and programs offered through the Blum, please visit our website, www.dana-farber.org/resource center, or email us at blum_center@dfci.harvard.edu. Thank you all for joining us. I will now pass the workshop over to Rachel Garcia Fox to introduce the panelists.
Thanks so much, Sierra. Hi, everyone. Welcome to a new Neuro-Oncology Wellness Education webinar. The Neuro-Oncology Wellness, or NOW program, is a new initiative from the Center for Neuro-Oncology at the Dana-Farber Cancer Institute, with a mission to educate patients and their caregivers about brain tumors, as well as provide resources to promote overall health and well-being. My name is Rachel Garcia Fox. I serve as the program administrator for NOW, and I will be your host for this series. Thank you so much for joining us today. We want you to be a part of this conversation by submitting your questions via the Q&A feature at the bottom of your Zoom screen. We will select a number of your questions for our guests to answer in the second half of the program. Today, I'm joined by Drs. Lee and Akilanti for a discussion on the diagnosis and treatment of brain metastases. Dr. Lee is the Director of Clinical Research at the Center for Neuro-Oncology and an Associate Professor of Neurology at Harvard Medical School. Dr. Lee is a recipient of the American Academy of Neurology Young Investigator Award and has been involved in translational neuro-oncology research for over a decade. Dr. Akilanti is a physician scientist at the Center for Neuro-Oncology and an instructor of medicine at the Harvard Medical School. Dr. Akilanti's laboratory research focuses on drug discovery efforts to develop novel therapeutics against oncogenic drivers in glioblastoma.
Thank you for having us.
Thank you for having us.
So we care for many patients with brain metastases here at the Center for Neuro-Oncology. Dr. Akilanti, can you start with an overview here? How common are brain metastases in cancer patients? And what are the tumors that most commonly metastasize to the brain?
Yes, of course. To start with an overview, brain metastases are when cancer starts from somewhere in the body and then spreads to the brain. And brain metastases are actually the most common brain tumors that we see in adult patients. And they are a very serious and feared complication of cancer that is considered, in some cancers, it happens early on, and in some cancers, it happens later. But it is estimated that between 100,000 patients to 300,000 patients will be diagnosed with brain metastases every year. And unfortunately, we think that the incidence of brain metastases, we're seeing that it's increasing over time. And that's because we've been able to come up with better treatment to treat cancers in the body, which means that patients do better, live longer, and unfortunately, over the course of their disease, they have a higher risk of developing brain metastases. And the incidence of brain metastases really depends on the primary tumor, but the cancers that more commonly spread to the brain are lung cancer, breast cancer, melanoma, renal cancer, and we of course see brain metastases across a large number of cancers, including also colorectal cancers, rarely prostate cancers, and others. And within each subtype of cancer, there are some that are more commonly spread to the brain. So, for example, within lung cancer, we see small cell lung cancer go to the brain very frequently, and about 80% of patients with small cell lung cancers develop brain metastases over the course of their disease. And similarly, within other cancers, for example, breast cancer, we see that aggressive types of breast cancer, for example, what we call triple negative breast cancer or HER2 positive breast cancer, they're more likely to spread to the brain.
Thank you so much for that overview and that information. Dr. Lee, let's talk about symptoms. What are the symptoms that patients experience prior to a diagnosis of brain metastases?
So the symptoms someone might experience is dependent on where in the brain metastases might go. So it's very highly variable how patients present. But in general, if we have a patient with known cancer who develops new neurologic signs or symptoms or cognitive changes, we want to look via imaging to see if there's any evidence of brain metastases. So some of the symptoms patients might experience include things like headaches, which the classic presentation are headaches that occur upon awakening in the early morning, headaches that can be associated with nausea, vomiting, headaches that are different than what the typical headaches a patient might experience, and headaches that are associated with focal neurologic deficits. Now, these deficits, again, they depend on where in the brain the lesion may be, but it could include things like weakness on one side of your body, or some vision changes, or difficulty walking. I also previously mentioned that patients can also have some difficulty with thinking, cognitive changes, some behavioral changes, and less commonly we can see seizures as well.
Okay, interesting. So it sounds like it can be several different things depending on the location. Dr. Aquilante, once a patient has found the lesions that are concerning for brain metastases on an MRI, what's the first step in terms of management?
Yeah, absolutely. So the management of brain metastases depends on several factors, it's very individual, depending on what the patient, on how many brain metastases there are, how large the metastases are, what is the primary tumor histology, and also how the patient is doing overall, what's their overall health status and well-being. But typically, the management of brain metastases now is multidisciplinary. So it involves a team of many different specialists that include neurosurgeons, radiation oncologists, and also neuro-oncologists and medical oncologists. Typically, the treatment can involve surgery up front, and that is if the patients have one large tumor that is causing compromise in the surrounding healthy brain tissue. So if it's causing a lot of swelling or mass effect, then we really should strongly consider surgery to relieve those symptoms and relieve that pressure into the normal brain. So that's when we consider surgery, and typically when patients have surgery, the surgery is followed by a course of radiation therapy. However, if patient has several different brain metastases, then at that point, surgery may not be as helpful. And at that point, we consider either radiation therapy or systemic therapy or a combination of both. And there are some instances where we would strongly recommend starting with systemic therapy over radiation therapy. And that includes certain subtypes of cancers that have really good systemic therapy for them. So, for example, melanoma or certain types of lung cancers that have these what we call oncogenic drivers that can be targeted by specific targeted therapies. So it really depends on a lot of factors. But the first step is always to discuss with a multidisciplinary team.
Great. Okay. Thank you. Yeah, we'll later hopefully get into the systemic therapies you mentioned a little bit more. I'm wondering, Dr. Lee, if you could tell us a little bit more about surgery. Is it always a consideration? It sounds like, Dr. Aquilante mentioned some possible scenarios where you wouldn't go down that route. Can you talk a little bit more about that?
Yes, exactly. So just to follow what Dr. Aquilante has already said, whether or not we pursue surgery really depends on the patient and a number of factors. We often consider surgery when we need tissue for pathology. So for example, if there's a lesion in the brain and we're not sure what that lesion represents, we will recommend surgery in order to obtain pathology and then know definitively what we're dealing with. Sometimes surgery is felt to be the best way to quickly relieve symptoms. Sometimes when it's the only lesion in the brain, there's some evidence that doing surgery for a solitary lesion could be beneficial. So we pursue surgery in those circumstances. There are other circumstances where the neurosurgeon might still offer surgery, but only really if it's in the best interest of the patient, if the benefits of doing the surgery outweigh the risks associated with the surgery.
Great. Thank you so much for clarifying that. And Dr. Occhilanti, let's talk a little bit more about radiation therapy that you mentioned. What are the different approaches available to deliver radiation therapy right now?
Yeah, absolutely. So there are two main approaches that we use to treat patients with brain metastases. And this is typically done under the guidance of a radiation oncologist who specializes in brain tumors. And the first is called stereotactic radiosurgery, or SRS. And that consists in delivering very, very high doses of targeted radiation only to the tumor itself. And this is the preferred modality for patients who have a small number of brain metastases and who have small tumors. And this is usually done over the course of a few days, sometimes even one fraction or a few fractions. And that this kind of therapy has the advantage that it can minimize toxicity to the normal brain because it directly targets the tumor. However, it has a disadvantage that it cannot attack either microscopic tumors that we don't see on the MRI or any cancer cells that we don't see on the MRI. But it can be very effective at treating the tumors themselves. And in some cases, we see that tumors don't come back in up to 70% of patients up at 1 year post-treatment. So it's a very effective modality, but again, it cannot attack areas of, if there are small metastases that we don't see. And the other modality is called whole brain radiation. And that is basically when the radiation oncologists deliver lower doses of radiation, but within the entire brain. This is done over several days, and the standard course is 10 fractions, so 10 days of treatment. And we might think about whole brain radiation in patients who have many brain metastases, or many large tumors, or patients who are otherwise not candidates for stereotactic radiosurgery or systemic therapies or surgical therapy.
Thank you very much for that overview. Dr. Lee, let's talk a little bit more about whole brain radiation. Dr. Occhilanti mentioned what kind of neurologic complications are expected with whole brain radiation?
Yeah, so whole brain radiation is associated with both early and late neurocognitive complications. So early on, some patients can experience some swelling from the radiation, and as well as fatigue and memory issues. But usually that's a temporary worsening that can improve over the coming months. But the most dreaded and main concern, long-term complication, is really the neurocognitive complications that can come months to years after the whole brain radiation. And really it's impacting multiple cognitive domains, including memory, processing speeds, the ability to multitask, the ability to learn new things. Some patients can even develop difficulty walking as a result of long-term consequences. This doesn't necessarily happen in everyone, but it is something that can occur. And the longer you live, the more likely you will see these long-term complications.
Interesting. Okay, thank you for going over that. I'm wondering, Dr. Occhilanti, are there any options to minimize the negative cognitive impact of whole brain radiation therapy?
So this is an active area of investigation now because, of course, we really worry about these long-term cognitive toxicities. And there are two main approaches that we use right now. One is the radiation oncologist uses a different protocol for whole brain radiation, which is called hippocampal avoidance radiation. And that prevents the delivery of radiation to the hippocampus, which is the part of the brain that controls storage of memory, formation of new memory, and memory retrieval. And this protocol was studied and was found to improve cognitive outcomes compared to standard whole brain radiation. So we strongly consider this for patients now, unless they have a metastasis that's in the hippocampus that we cannot, where we cannot use this protocol. And then another strategy is to prescribe a medicine that's called memantine, that we start with the beginning of radiation therapy and continue for up to months after the radiation therapy is complete. And this also was studied in some clinical trials and found to lead to a reduction of these cognitive toxicities of whole brain radiation.
Interesting. Thank you. Dr. Lee, let's go back quickly to stereotactic radiosurgery. You mentioned worsening symptoms, maybe temporary worsening symptoms. Why is it that you often see that with the stereotactic radiosurgery specifically?
Yeah, when you deliver stereotactic radiosurgery, you're delivering a very high dose of radiation to a very small area, just like Dr. Acqualanti previously mentioned. So you can imagine that that can cause some swelling, temporary swelling. And when there's swelling in the lesion, then the neurologic issues that you may have as a result of that lesion can temporarily worsen. Sometimes we have to use steroids to bring down that swelling. But with time, generally, the swelling does get better on its own.
Interesting. Okay, Dr. Acqualanti, besides corticosteroids, are there any other therapies that are considered for treating inflammation around the tumor or even radiation necrosis?
So there are. So in some cases, patients cannot tolerate high doses of corticosteroids. So, for example, patients who have diabetes, they might get uncontrolled blood glucose. So there can stay on high doses of steroids for a long time. Or sometimes the steroids are just not effective enough at controlling the swelling. So in those cases, we consider another medication that is called Avastin or bevacizumab. This is an IV infusion that is given every 2 or 3 weeks. Avastin is an antibody, a monoclonal antibody that targets a factor that's called VEGF, or vascular endothelial growth factors, which helps with the formation of blood vessels. But we also know that targeting this pathway is effective at controlling swelling and edema in the brain. And the Avastin was found to lead to good responses, both imaging-wise, so reducing swelling on the MRI, but also improving neurologic symptoms related to swelling, and also reducing corticosteroid doses.
Interesting. Thank you. I think we're going to shift gears a little bit now and talk about some new systemic therapies. Dr. Lee, in the last decade, we've seen a number of new systemic therapies for different tumors, some of which have activity in patients with brain metastases. Can you tell us a little bit more about the development of these therapies? And then I'll ask you both about treatments for specific diagnoses.
Yeah, so this is a very active area of research. I mean, historically, clinical trials unfortunately excluded patients with brain metastases. So for a long time, we didn't have great data about which systemic therapies, chemotherapies get into the brain and which ones can help patients with brain metastases. But there's been an active push within the academic community, within the FDA, within the NIH to really try to develop better therapies for patients with brain metastases. We know that this is an unmet need. And there has been an active effort really in the community, also driven by patient advocates, to include patients with brain metastases into clinical trials. That's the only way we'll know if these agents can be helpful or not.
That's great context to have. Dr. Acqualanti, tell us what systemic therapies, specifically targeted therapies, are available for patients with lung cancer.
So the treatment for lung cancer has really been revolutionized over the last decade, and that's because of these targeted therapies, molecular targeted therapies. And these are therapies that are given to attack specific drivers of the cancer. And in lung cancer, there are certain patients who have mutations in these oncogenic drivers. Some of these drivers are called, for example, one of them that's frequently mutated is called EGFR, or epidermal growth factor receptor. Another one is called ALK, or anaplastic lymphoma kinase. And these mutations now can be attacked very effectively with targeted therapies that are oral drugs. And patients respond very well initially to these therapies. So at the beginning, it was unclear whether patients with brain metastases would respond because it was unclear how well these treatments got into the brain. But now we do know that some of these treatments get into the brain quite well. So an example is for patients who have lung cancer with this EGFR mutations. There's a drug that's called osimertinib or Tagrisso that can get into the brain quite well. And this is actually first line if there is a patient with EGFR mutant lung cancer, specific mutations in EGFR, brain metastases that are not where the patient doesn't have a very large burden of brain metastases, that are not causing a lot of significant symptoms. We do start Tagrisso up front. So this is very exciting because we can spare whole brain radiation for these patients at the beginning. Another example is patients that have lung cancer with ALK mutations or translocations. And there are several options available for these patients. Some of these drugs are called, for example, alectinib, lorlatinib, brigatinib. These are targeted therapies that we do know that can penetrate the brain quite well.
Wow, very exciting time to hear about these developments, know that they're available for patients as options. Dr. Lee, let's talk about breast cancer. Can you tell us a little bit about what systemic therapies are available for breast cancer patients?
Yeah, so for breast cancer patients with brain metastases, the most recent developments have been in patients with HER2-positive disease. So this is a subtype of breast cancer. And there have been a number of recent studies that have demonstrated really exciting results for patients with brain metastases. The HER2CLIMB study demonstrated that the combination of another targeted therapy, again targeting HER2, called tucatinib in combination with capecitabine and trastuzumab, is helpful in patients with brain metastases from HER2-positive breast cancer. There's another study, again in HER2-positive breast cancer, that demonstrated that trastuzumab deruxtecan or TDXD also has some benefit. There are older studies as well that have looked at other HER2 directed therapies, including neratinib plus capecitabine and lapatinib plus capecitabine, and still in a very active area of research.
Interesting. Okay, so it's good to know that the mutation, the HER2 mutation, right? That's what we would call that, is kind of a driver for the cancer. And so some of these treatments work for people who have those diagnoses with the particular mutations. But, Dr. Occhilanti mentioned something earlier. I just want to circle back to it, like triple negative breast cancer, for example. There's an option like that for those patients, because they would be negative for a mutation like HER2. Is that correct?
Yeah, there are also studies looking into triple negative breast cancer. These are people who are HER2 negative, but also ER/PR negative. So those are our hormone receptors. An active area of research, like I said. The studies are not quite as far along as what we can see with the HER2 positive breast cancer population. There are also separate studies for people who are HER2 negative but positive for the hormone receptors, whether that be estrogen, ER, or progesterone PR. There is some, typically for those patients, we often use CDK inhibitors in combination with hormone-driven drugs.
Okay, so there are still options, just different ones. And it sounds like, this is still a very active area of research, as you're mentioning, with the interest in the community and such. Thank you. Dr. Occhilanti, let's move on to melanoma. What's available for patients with metastases from a melanoma cancer?
Right. So in melanoma, there are two lines of therapy that have been shown to be effective. One is immunotherapy and one is targeted therapies. And for patients with melanoma and brain metastases that were previously untreated and that are not causing a lot of symptom burden, A significant number of these patients respond well to immunotherapies. So a combination of two immunotherapies, ipilimumab, nivolumab. So that's something we consider when patients have brain metastases that are untreated before. And also patients who have melanoma with one of these oncogenic drivers called BRAF, specifically BRAF V600E. This mutation can be targeted by targeted therapies, combination of BRAF inhibitor and MEK inhibitors. So we consider this combination in patients with brain metastases and BRAF mutant melanoma.
Great, thank you. Dr. Lee, you mentioned it already a little bit, but at a previous webinar, we discussed the use of immunotherapy for patients with primary brain tumors. And I'm wondering if we could talk a little bit about the current research that's going on. I know you're leading some very important clinical trials in this area, looking at immunotherapy in brain metastases patients.
Yeah, so Dana-Farber has participated in several studies that have looked at immunotherapies for patients with brain metastases, or even leptomeningeal metastases from different primary cancers. And there has been some modest benefit, but it also depends on the patient population, the underlying cancer. So there are larger studies that have demonstrated the role of using immunotherapy for brain metastases from metastatic melanoma, just like Dr. Esquilanti already discussed. There's also been studies that suggest that you might be able to use it even in patients with brain metastases from non-small cell lung cancer. And there have been a variety of other smaller studies that have looked at different kinds of cancers. The study, like I mentioned, that we participated in, a phase 2 study of an immunotherapy drug called pembrolizumab. We saw, and again, it was a very small study, so it's hard to say for certain how beneficial it is for all of these patients. So there still needs to be ongoing research, but we saw some benefit in some patients with brain mets from breast cancer and sarcoma as well.
Interesting. Okay. Again, active area of research, so I'm sure there's more to come. Dr. Esquilanti, what kind of toxicities are seen in patients that are receiving immunotherapy?
Sure. So with these immunotherapies, and when I'm talking about immunotherapies, these are specifically immune checkpoint inhibitors. These are drugs that they work by taking the brakes off the immune system. So they basically stimulate our own immune system to attack the cancer, which is very exciting. However, sometimes by taking the brakes off the immune system, you can cause the immune system to actually attack healthy organs as well. So the toxicities that we see from immunotherapies are more related to these phenomenon that we call immune-related adverse events, more than other toxicities that we see, for example, with chemotherapy. So patients who are treated with immunotherapy, they typically don't have as much of the nausea or hair loss or suppression of their blood counts as with chemotherapy. However, they can have there are these instances where the immune system can be woken up too much, and so it can attack normal organs. And the ones that are more commonly affected are the skin. So patients can develop rashes, the gastrointestinal tract. So sometimes patients can develop diarrhea. Colitis is a pretty common one. They can also attack the liver. So we can see that the patients have a elevation in their liver enzymes. Sometimes the lungs are affected, so people can develop cough or shortness of breath. And then another organ system that's sometimes affected are the endocrine glands, including the thyroid, the pituitary, and adrenal glands. But I want to say that in the majority of cases, immunotherapy are tolerated quite well. We do monitor for these toxicities routinely when we see patients, both by physical examination, listening to their lungs, and also looking at blood work. So we always check for the liver, the kidneys, we check for thyroid function, adrenal function. And we monitor for these toxicities closely, very closely over the course of treatment. In some cases, the toxicity can be serious, but serious toxicities are rare and they happen in less than 1% of cases.
Wow. Okay. Thank you for that information. Dr. Lee, you mentioned leptomeningeal metastases before, I think. So this is the type of difficult to treat brain metastases, metastases involved in the coverings of the brain and the spine. What's new regarding the treatment of these types of metastases?
Yeah, so this is another area of unmet need that's an active area of research. So the leptomeninges, or like you mentioned, the covering of the brain, is a different compartment than the brain itself. It's the compartment where spinal fluid lives. And just like it can be difficult to get drugs into the brain because of the blood-brain barrier, there is a blood CSF barrier as well. So it can be very difficult to get drugs into the spinal fluid spaces or the leptomeninges. Leptomeningeal metastases occur less frequently than brain metastases. So there isn't as much research into leptomeningeal metastases. But there is some data that some of the drugs that are used in brain metastases could potentially be helpful in leptomeningeal metastases. Again, because the numbers of patients are smaller, we don't have as much data regarding that. But there is some data, for example, in EGFR mutant lung cancer with leptomeningeal metastases. The EGFR inhibitor osimertinib can be potentially helpful in leptomeningeal metastases from EGFR mutant lung cancer. There was also a smaller study looking at tucatinib, capecitabine, trastuzumab. This is the combination that's used in HER2-positive breast cancer brain metastases. So there was a smaller study also looking at leptomeningeal metastases, again, from the HER2-positive breast cancer population. So again, an ongoing area of research, but still definitely an unmet need.
Thank you. Dr. Occhiolanti, I just wanted to give the opportunity to mention our other latest clinical trials available at Dana-Farber for patients with brain metastases. I know that each of you mentioned a few either past studies or current studies, but is there anything else going on right now that is worth mentioning in this area?
Yeah, absolutely. So we have several at Dana-Farber. There are several clinical trials for patients with brain metastases that are run by either us in neuro-oncology, but also our radiation oncology colleagues and then our colleagues in our disease-specific groups. So, for example, on the radiation front, there are several studies. There is a study specifically looking at comparing stereotactic radiosurgery with hippocampal sparing whole brain radiation in patients with breast cancer brain metastases, patients who have between 5 and 20 metastases. So they're comparing these two different modalities in this population. There's also another study looking at a specific type of nanoparticle that might make radiation more effective in patients with brain metastases. There are several studies run in the breast cancer group for patients with brain metastases. We have open trials of what we call genome-guided therapy. So that means that we look at, across histologies, we look at mutations in the brain tumor themselves, and then we assign patients to specific treatment groups depending on those mutations. So if there are therapies that can target those mutations. There are studies of immunotherapy in brain metastases, so that there are definitely a lot of open trials.
Fantastic. Thank you so much. And thank you both, Dr. Lee and Dr. Occhiolanti, for this terrific and very comprehensive discussion on brain metastases. It sounds like, if we do this talk in a year or 2 years, there may be some updates because of all the research that's currently going on. I wanted to give an opportunity for both of you to give us any take-home points that you'd like to leave for our audience today on this topic.
Sure. So I think, I'd like to say, of course, having a diagnosis of brain metastases is extremely devastating and scary, and it's overwhelming. But this, as we heard today, is an area of active research and active investigation. There are a lot of new therapies coming up, and we as a clinical and research community, we are developing treatments that are going to change the standard of care in the short term and in the long term. And so if any patient who is diagnosed with brain metastases. If you have any questions, if you want to reach out to us to talk about what are the options, what are some trials that are available right now for your situation, feel free to reach out. We're always here to help.
Thank you. Dr. Lee, would you like to add anything?
Well, I echo Dr. Aquillante's statements. Again, we're actively trying to find better treatments, and we remain hopeful for the future.
Thank you both so much for coming on a Now webinar. And thank you to the audience too for joining us today. I want to just say we are going to actually not be having a webinar next month. So our next webinar is going to take place in December, and an email will go out about that if you are subscribed to our mailing list. And this will be a Now webinar where we're going to be joined by Dr. Patrick Wen for a discussion on clinical trials in neuro-oncology. So we hope to see you there. If you have any questions, feel free to put them in the chat, and I'll also have our email address in the chat that you can use to send us any questions at all about the program or follow-up questions about today's webinar. Thank you so much. Take care.
Thank you for a great and informative program, everyone. As we mentioned earlier, the session was recorded and will be posted on our Blum YouTube playlist. So look out for that. And thank you all for joining us.